thank you everybody for coming to the kickoff for the Engineering Health Equity Hackathon, which is being hosted by the MIT Hacking Racism Challenge, Race to Better Health, and Atrius Health this year. So my name is Freddie Nguyen. I am a research fellow at MIT, as well as a resident physician at Mount Sinai Hospital in New York. I've been former co-director of MIT Hacking Medicine, helped launch the MIT COVID-19 Challenge last year, as well as the MIT Hacking Racism Challenge. I wanted to pass it out to some of our partner organizations. So turn over to Lydia to introduce herself.
My name is Lydia Flyer. I'm a primary care physician at Mount Auburn Hospital and an instructor of medicine at Harvard Medical School. And I'm also the co-founder of Race to Better Health with Dr. Jamesia Connor, who is still in the OR tonight. Just briefly, I'd like to say one or two words about Race to Better Health, if that's okay, Freddie, or does that come later?
Go right ahead.
Great. So I just wanted to kind of introduce Race to Better Health to everyone briefly. We are a patient-centered interdisciplinary organization that came together in the summer of, I guess, 2020. Feels like even longer than that now. And our vision is to be a trusted leader in the health inequity and equity space with the goal of activating interdisciplinary and cross-sector solutions. Our goal is to build a more equitable healthcare landscape, and we want to do this by bringing together patients, practitioners, professionals, researchers, communities, and organizations to build collaborative and interdisciplinary solutions. We are so excited to be a part of this hackathon because we view the obstacles to progress in health equity to include things like a fragmented health equity community, which is why we're so excited to bring together people from all aspects of the community, a rigid healthcare system, which is why we're excited to be part of a hackathon that really flexibly tries to come up with solutions and build teams and come up with proposals on a rapid scale, limited patient involvement, which is why we're really excited to have people from all walks of life here with us, and a broken innovation to translation pipeline, which is why we're so excited to be partnering with both MIT Hacking Racism and Atrius to really create this pipeline from beginning to end and to really focus on problems that we hope can be solved in the near future. So we are so excited. You can find us at racetobetterhealth.com, and I'm sure you'll be hearing a little bit more about us this weekend. And I will pass it back to Freddie, and you'll be meeting Jamesia, Connor, and some of our other team members later.
Turn it over to Joe to introduce Dr. Strongwater.
Yeah, so good evening, everyone. My name is Joe Kimura. I'm working with all the great team members here for this event. We're super excited. I serve as Chief Medical Officer here for Atrius Health, and it's my privilege to introduce our President and CEO, Dr. Steve Strongwater, to say a couple words about our practice and then, about the event. So, Steve.
Thank you, everyone, and thank you so much for joining us. We are the laboratory where we are going to make change happen. We're a large primary care-based practice with about 700 physicians inside the greater Boston area. I cannot thank you enough. We are honored to work with MIT Hacking Racism and Race to Better Health, and with all of you to confront the health equity challenges head on. We're excited to see the many ways your passions, skills, and personal experiences will help us transform the lives of our patients, the providers, and the broader healthcare community. We believe this is a pivotal and powerful moment for change. No pressure, but we're really counting on all of you this weekend. So get your thinking caps on and help us make healthcare a much better place to practice medicine. Thank you so much.
This is exciting. And honestly, it's a privilege to be working with such sort of dedicated folks across the community. And it's exciting to see the names and people coming from literally all over the country and the world too, participating in this. So really important stuff. And I would echo what Steve said. The moment is now. There's a moment in society that we can capitalize on. So really excited to be part of this. Thank you.
Thank you, Joe. Thank you, Dr. Strongwater. And thanks to both Race to Better Health as well as Atrius Health for really being our co-partners as part of this event, the MIT Hacking Racism Challenge, as mentioned, was launched last year, really to bring a lot of the MIT mentality for problem solving and tackling tough challenges with healthcare equity certainly being one of those. Of course, we couldn't have done any of this work at MIT or particularly in this hackathon without really the ecosystem of organizations that have come together, both within the walls of MIT and outside the walls of MIT. And that's been, I think, always been the strength of these hackathons that we've done. It really does bring together the full community and the ecosystems to tackle these challenges. Really thinking about everybody from the academic side to the clinical side to other groups as well. So, and I think you'll see that in all the participants that are here and the mentors and the types of organizations or places that you're representing or coming from. Everyone is bringing a very different perspective and a valued perspective to this process and to these problems. And so with that, we'll kick it off with our keynote speaker. So I'd like to start off by introducing Beatriz Cantata, who is the Director of Engagement for Diversity and Inclusion at MIT. Beatriz.
Thank you, Freddie. Good evening and good morning and good afternoon for folks joining us from different time zones. My name is Beatriz Cantata. I use a she pronoun series. I work in the Institute Community and Equity Office, ICEO, as a Director of Engagement for Diversity and Inclusion. Welcome to MIT's second Engineering Health Equity Hackathon, where we all work together to find creative and concrete solutions that can make access to high-quality healthcare more equitable. Hackathons are so MIT. You're not here to talk about health equity. You're here to make things and make things better. Thank you. This is an exciting time for the MIT community. Like you, we are taking steps to put some of our own ideas into action. We are in the process of completing the first ever institute-wide strategic action plan, diversity, equity, inclusion. Note word action in there. This plan will demonstrate our commitments to increasing diversity and promoting equity and a sense of belonging across the Institute, and will serve as a framework to measure progress and build accountability on mutually agreed upon goals. And at the same time, we're planning, we're acting. MIT has hired over 15 diversity leaders all across campus to implement the strategic plan and to provide their expertise in improving community culture. The people who are doing this work, including me, believe deeply in the issues we are seeking to address. The challenge for many of us is figuring out exactly how to improve the lives of the people we are seeking to support or lift up. The wonderful thing about this hackathon is how real it is. You are here to make things people can touch, use, and experience or interact with directly, things that will materially affect their daily lives. You don't just imagine equity in data, healthcare, and AI. You're here to work together, to learn from each other, to create shared meaning about these concepts, maybe in ways you haven't thought of before, and then make it real in new and exciting and relevant ways by Sunday. Collaboration and innovation are at the heart of MIT. We learn by doing. Hackathons are one of the ways we embody MIT's commitment to generating, disseminating, and preserving knowledge and to working with others to bring this knowledge to bear on the world's great challenges. I look forward to hearing your pitches on Sunday and witness your solutions come to life with the tools, resources, and partnerships available to you.
Thank you so much, Beatriz, for that very welcoming remarks from really the MIT community to everyone who's in attendance tonight. So next, I'd like to introduce Gil Addo, who is actually the CEO and co-founder of Rubicon MD. Unfortunately, Gil couldn't join us live, but he did have a fireside chat pre-recorded that we'll be playing now.
Thank you for having me. I appreciate the opportunity to come back. You know, you can talk a little bit about it, but this is where it all started for us.
So tell us a bit more about kind of what went into, or how did you approach coming into a hackathon to begin with? What was your initial motivation, and kind of describe a little bit of your experience through that initial lens?
So just for context, so we're, Rubicon MD, we're an 8-year-old digital health platform on a mission to democratize access to medical expertise. And I entered the hackathon. I'll just set the context. I'm trying to get the exact dates right. I had just quit my job. I think I was probably still working, but I just quit. And I was setting out on this entrepreneurial journey. Some of the folks I worked with, including my one of my office mates, while in my previous role, had told me about these hackathons, and specifically about MIT Hacking Medicine. And they basically said, like, if you need to find people to collaborate on this with you, this is a great place to go and launch and to build partnerships with folks who could potentially help you get this off the ground. And so I applied. It was one of the folks fortunate to be able to join, and I approached it from the perspective of I was looking for people who would be interested eventually in starting something together with me. And so, but I was also looking for validation, critique, and to advance the idea. So I came in somewhat with an open mind. I think also when you're starting a business, or even just interested in starting something, you don't really know where to start. You don't have a whole lot of structure. There aren't a ton of resources. And so this is a great place to just go in a pretty low cost way, learn and explore, and see if it sparks something that could be turned into something great. So that's kind of what I approached it with. If I'll be honest, I was looking also for somebody with technical expertise. My co-founder, Carlos, who I met there, doesn't have technical expertise. We're both biomedical engineers, but neither one of us really can code. And so it turned out to be a blessing, because what we're building is actually a business model innovation. And so solving for that and having his unique operational mindset around actually really how do you hack something to get it to the next stage, turned out to be exactly what the business needed. And we were pretty shared set of values and principles. And so it ended up being the perfect co-founder marriage there. But that's what I came in for initially, was thinking, I need a CTO to be able to build this to the next stage.
And tell us more about the hackathon experience itself.
It's such a concentrated period of just focus. How much can you get done to validate this and to prove or disprove hypotheses. In that weekend, I'd say I made more progress towards this in my entrepreneurial journey than I had in the previous year. Now, that's not an exaggeration in the least bit. It was just such a focused experience. I came in with a loose sense of the problem that we wanted to solve around enhancing access to specialty expertise, and an idea for how to solve it that I'd been noodling on for, at that point, about a year. But to be able to work with really, really smart people, go out in the field, and I can speak to, what the experience was at the first hackathon. We ended up doing 2 more hackathons after that to really advance the idea in the business. But at that first hackathon, we were able to get several people with different expertise together, put together an MVP prototype, actually go out to clinics and get feedback on it. And then there were a number of mentors floating around who had different thoughts, perspectives. I remember, I can actually see him. He ended up being on the staff at Hacking Medicine for a while, but I remember we were there and we were talking about it, and we initially talked to him about the interaction around primary care getting opinions, and we essentially said it's, you know, a Skype-like thing where the specialist gets kind of brought in virtually. And he was like, why does it need to be synchronous? And it was a good question. We didn't know the answer, and we started to think really hard, and then we just understood a little bit more about how important the specialist was as the most critical piece in the value chain. And so can you optimize around their time with a slightly different model? And so we pivoted to an asynchronous interaction, which the way it works, patients go to see the primary care clinician. The primary care clinician goes to Rubicon MD and gets opinions from a network of specialists across the country. And so it's like that type of like critical, you know, pushing and questioning and support from a number of mentors. And there are some others there. Michael Barnett is somebody who didn't actually stay with, you know, working with us, but was there from the very beginning and went on to have a really prolific career in academia. We've collaborated on different things in areas. So it's also the ecosystem and the folks that you're able to build the relationships with who help to grow the venture. Not everybody at the hackathon, you know, went on to pursue an entrepreneurial venture. Most people didn't, but they all became, you know, really good collaborators. They produced, you know, they got the experience of learning. They became part of the network that we've tapped for the business. And it's all been part of this broader ecosystem around innovation. So yeah, we've done, you know, I've been to events and supported where nothing came out of it, but it was a really great, like, you disproved a theory on something that could have been great. And now obviously we built a really big business around something that we knew was a real problem, and we were able to navigate some of the twists and turns by getting this accelerated kind of prototype and view. And like I said, I made as much progress in a weekend as I had in the previous year. And so you can really build a business like actually through a weekend and a hackathon. And we now have taken the same approach, and at Rubicon MD, we have some like hackathons that we build in when we need to, you know, get to some decision, or we need to kind of get to some solution and learning. And it's a really, really productive way to just put a number of people and solve a problem really quickly.
How much were you, it sounded like you were able to use a decent amount of it, but how much of that, those relationships developed at the hackathon or the ecosystem you were able to tap into through the MIT hackathon that you continued with, you know, long after hackathon itself?
Yeah, there are a number of them that we've kept in touch with. You know, the initial hackathon was obviously was in Boston at MIT. We ended up moving and starting the company in New York. But those early relationships are, you know, some of our closest friends and supporters, and people we've collaborated in different settings. Not all of them, but, you know, I can say from one of the hackathons, there was a guy there who was also a classmate of my co-founder, Carlos, named Michael Poku. Michael ended up being one of our champions at the company that acquired us, Oak Street Health, that acquired us 2 weeks ago. And so that's 8 years later. And that was a relationship developed, you know, at one of these early hackathons. And he helped, and he thought through some of the ideas and the things around the business. Didn't stay involved directly. We would have loved to keep him, but, you know, went on to do some great things. But like I said, has been a huge champion, a huge supporter, and to some extent, one of the people that helped create, you know, incredible value for us near the end. And I think there's a number of other people that I could point to, like that I mentioned, Michael Barnett, who's become a huge champion of the e-consult space and published a number of things in literature. And then there are people who've been less, you know, more loosely involved. Leslie Solomon. There are people who've just turned into clients of ours. Zen has remained a champion, and doesn't miss an opportunity to tout Rubicon MD and remind people that where we started. So it's been, I'd say the ecosystem is as important, and I could keep going on and on, with a number of people who were really early, who helped support, I think Andrea as well. So anyway, the ecosystem is as important as the actual service and offering, because you will build and accelerate things very quickly in a short period of time. But you will then need to take that and go and figure out, how do you get this to the next step in the next stage? And so the people, not just the mentors, but the people that are there at the hackathon with you, become that community to help enable this, regardless of whether or not they stay directly involved, especially if you want to turn this into a big business, which was always my aspiration.
So since we're kicking off into the Engineering Health Equity Hackathon, the health equity space in itself is even more complex than most of the things that we've targeted our hackathons towards in the past. Hackathons tend to also produce more technologically oriented types of solutions, and the issue of the digital divide in terms of access to especially under served areas and populations. Any tips or advice on, especially given the work that Rubicon MD has done, is in terms of how participants should think about ensuring that, or self-checking that they're not introducing even broad, widening the inequity through technology development?
Yeah, all the things we talk about around telehealth equity are about, how do you provide things into the community that people will actually use? Like, I think the lessons that that really should be the underpinnings of this hackathon is that if you build it, they will not come. Like, that is not truly the case in these underserved communities. And so I think what you said, the digital divide and not everybody having access, particularly in a lot of these underserved communities, is one key piece of it. My wife works at the Harlem Children's Zone, and they do a lot of work around, how do you provide better broadband and access into Harlem specifically, but communities that have been underserved. And it's not a technology problem, it's a financial problem. And that's the first piece. The second piece is, how do you arm the people that actually support the communities? And so, yes, you can give, access to, a doctor in whatever, ivory tower, for lack of a better term. But there are people who serve these communities, who understand them, who are culturally competent, and work within them. How do you make sure those people are armed with the resources they need? And then the third piece is, how do you actually meet the community partners where they are, or meet people in the community where they are through community partners. And so, like I said, assuming people will come just because the app works is not, a real strategy. How do you, approximate community groups, churches, other resources, and folks who actually have direct ties into that community, and use those people as conduits to get the word out? I think one of the learnings of COVID is people don't trust the person on TV. They trust the person in their community that they have a close relationship with. And so I think technologists need to think not just about what's the tool and service, but how do you get it to people in a way that they will receive the information and actually use it. And then, like you said, making sure that, it works in a way that can be, smartphone enabled, and that people will be able to use it even if they don't have necessarily access to computers and the like. So I think there are a lot of people who are thinking hard about these problems, but I'd say at the core, it's about understanding the community and the context. And that's probably, from a hackathon perspective, the most important thing you can do is to go and really understand who the people are that are going to use this, and understand the context in which they're using it. Can I just say, first, kudos to you for doing this. I think it's incredible. And secondly, if I was going to say, the only thing, at least for me personally, the only thing that I think is a worthwhile use of time to work on is things that are solving these problems right now. I'm oversimplifying. There are other problems in the world, but like this is where I'd want to be putting my brain power to, and these are things that will drive our healthcare system forward in a meaningful way. So first, kudos to you, and this is the stuff that people should be spending their time on. These events and this ability to work in a really, really short and contained time period to solve real problems can be powerful. And I think we are, as with the other groups that you can point to, we are one of the examples of what you can do in a weekend that can then have impact, that can address and solve problems for millions of lives. We covered over 10 million lives at this point. And so there's real impact that you can have just by focusing and working a weekend with the right set of minds who are interested and passionate about the same problems. So good luck. And I think there's nothing more noble than the work you guys are doing to really solve these problems.
Great. So for those of you who don't know, so Rubicon MD was actually started out of a hackathon that MIT Hacking Medicine did back in 2013 now, and 8 years later now was just recently acquired by Oak Street Health for $130 million in cash plus another $60 million in stocks and cash based on performance. So it really shows you that something that started a hackathon weekend can have real meaningful impact, can have long-term success. So with that, I'd like to introduce you to Andrea Ippolito, who is no stranger to our hackathons as well. She was formerly the co-director for MIT Hacking Medicine, and has also an alum of MIT, and is now the CEO and co-founder of SimplyFed. Andrea?
Well, gosh, I'm so honored to be here. So thanks so much for having me, Freddie and team. And this is such an incredible event. So rock on for you all being here. I'm so psyched to see what you all come up with and tackling these really hard, gnarly problems. And so, as Freddie said, my name is Andrea Ippolito, and I used to be very involved with hacking medicine when I was a student. And this is a picture of some of our hackathons. But along with being an organizer of the hackathons, and the big takeaway there is, if you give to the community, you get so much back. So be an organizer and be a part of the community. But along with being an organizer, my first company that I co-founded, Smart Scheduling, came out of one of the hacking medicine hacks. And the goal of Smart Scheduling was a predictive algorithm that predicted no-shows to medical practices. And just to zoom to the end of the story, it eventually was acquired by Athena Health. And that was such a wonderful opportunity for us to see Smart Scheduling continue to realize impact. And that's the goal of today, to make impact. You're all going to be in the short sprint and going to be iterating on concepts, a lot like what Gil talked about. And so use this time to get to know each other, identify the problems, but then iterate very quickly based on the needs of the community. And so fast forward, I went to government for a bit, based out of the White House Office of Science and Tech Policy as a Presidential Innovation Fellow, where my appointment was at the VA. And then after that, I had my first daughter, May. And the thing about my first daughter is that she was born early, she was born underweight, and I had tremendous difficulties breastfeeding. It was really hard, and my daughter kept losing just a tremendous amount of weight. And it was one of the most difficult moments of my life. And I truly felt, as a first-time parent, that I had failed at my first task as a mom. I was very hard on myself. It impacted me mentally, it impacted me physically. And it honestly reminded me a lot of when I was a grad student at MIT, where my research was with the chairman of the Joint Chiefs of Staff on how we could implement and scale telebehavioral health systems of care for service members faced with post-traumatic stress. You see, there would be service members that would be, say, at Fort Campbell, and 20,000 service members had been deploying back from Afghanistan. And so their psychologists were extremely overwhelmed. And then you went to the other side of the country, where their service members, 20,000 service members, were deploying to Afghanistan. So their psychologists were underutilized. And what happened with the military is that there was a supply and demand problem, is that people weren't being used to the highest level of utilizations in a way that could increase access to care. And it reminded me a lot of this experience as a new parent, because I thought, here I was at the time and still am living in a pretty rural area, and I needed access to support. And I needed access to support in my own home at 2 a.m. when I was going through this really intense, really emotional experience. And to take a step back, the reason why I really wanted to breastfeed was because breastfeeding is awesome. It's such an important public health intervention. Breastfeeding for babies reduces the risk of illnesses, ear infections, diabetes, GI diseases, SIDS. The part that people don't talk about, though, about breastfeeding is the impact of breastfeeding on mom's health. Breastfeeding reduces the risk of ovarian cancer, breast cancer, endometrial cancer, and particularly surrounding birth. Breastfeeding reduces the risk of postpartum blood loss, which is the #1 killer of moms in and around birth in the United States. And pretty devastating levels, especially Black women. And so breastfeeding is a tremendous public health intervention that we need to support. And the thing about breastfeeding is that for every $1 you spend on breastfeeding support, you get $3 back in cost avoidance. With the Medicaid population, you save on average about $475 a month for every baby that's fully breastfed versus fully formula fed. And so there's so much that can be done here. However, women are abandoning breastfeeding way sooner than they want to. And let me just say, I just had my daughter 6 months old. Breastfeeding is super duper hard. But the thing about breastfeeding is that 85% of people start off breastfeeding, but only 25% are doing it up to the medical recommendations, which is 6 months. And these are recommendations put out by the American Academy of Pediatrics, American College of Obstetricians, the CDC, the Surgeon General, and the World Health Organization. So that's an insane discrepancy in the number of people that want to breastfeed. We know it's good for mom and baby health, and the number of people that actually can and reach their goals. And the reason why this is so important, not just for physical health, but for mental health, is that when a mom doesn't reach her breastfeeding goals, she's 4 times more likely to be diagnosed with postpartum anxiety and depression. So this is a huge issue. And the thing is that there is a tremendous resource out there called lactation consultants. And this is a clinical specialty. And the ultra cool thing about lactation consultants is that this is a reimbursable expense. Under the Affordable Care Act, we're required to cover lactation consulting under commercial health plans and Medicaid plans. So there's a solution. There's a reimbursement option, which is one of the biggest, baddest bureaucratic mechanisms you have to figure out. And there's an opportunity here to really help intervene for this public health crisis. But the problem is the system is so broken right now. People don't know how to access the support. And even though health plans are required to cover it, sometimes it's just tremendously difficult to get it covered. So in the current state, lactation support has become a service of the privileged. And this is bad for mom and baby health. It's bad for all the public health reasons I mentioned. And it also increases costs for the entire system. So what we're doing at Simply Fed is we're surging support via telelactation. And we think this is such a huge opportunity to tackle this public health crisis that we're facing. And because it can help surge support into the convenient setting of your home, even outside of COVID-19, where once you have a little baby, you're so nervous to go out in public. And so by surging support, virtual support, we can help increase access to this very important needed service. And so I founded my company Simply Fed, and we have a tremendous team of lactation consultants based all across the United States, where we surge support via our virtual care model. And to Gil's point, we have tremendous partnerships with all sort of stakeholders across the healthcare system. We collaborate with folks like University Hospital in Newark, New Jersey that refer to us. We partner with community doulas in places like Trenton, New Jersey that refer to us. And once a parent presents to us, they text us, we get them scheduled for an appointment. And then we have this ongoing telelactation model where we work with them virtually from the comfort and safety of their own home to help increase breastfeeding initiation and duration. However, the current issue in the system is that unfortunately lactation support and these lactation consultants, which are called internationally board certified lactation consultants, are predominantly staffed by white women. And right now, close to 90% of IBCLCs are white, compared to less than 2% are represented in our Black International Board Certified Lactation Consultants. And this is tremendously important for 1,000 reasons in order to provide culturally competent care. But just to put out the data of why this is particularly important is that Black newborns in the United States die at 3 times the rate of white newborns. And a recent study published in 2020 found that newborn physician ratio concordance is associated with significant improvement in mortality for Black infants. And so if we can bring more lactation consultants that are providing culturally competent care, but also are among the community so they can reach people where they're at, then we can help increase breastfeeding rates. And this is tremendously important to tackle this maternal mortality crisis we're facing. And so what we're doing at Simply Fed is we're working to not just increase the supply of lactation consultants in the community to increase access to care, but we're working to diversify the lactation workforce. And the way we've done that to really tackle some system level change so that whether or not Simply Fed is successful or not, we're creating systems level impact that's here to stay without us. And the way we're doing that is first we started researching and collaborating with stakeholders at the Chan School to really understand what's happening in the community, to meet them where we're at, understand the need, not make any assumptions. I thought Gil's comments were so thoughtful because you have to understand the problem to solve first. So we took the time to research the problem. And what we've developed is a pilot and demonstration project with community doula groups, and particularly focused in the state of New Jersey right now, which is ranked 47th out of 50th in terms of maternal mortality. And right now, we've developed a lactation training program in collaboration with the existing credentialed programs called the Certified Lactation Consultant Credential. And we're training community doulas across the state to become lactation consultants. In this way, they can be in the community, and to Gil's point, they can be in the places that people interact and get to know people in those communities, whether it's in church groups and hospital settings and on the corner and stores, whatever that is, they're among the community and can be helping to provide breastfeeding support to new parents when and where they need it. And then our goal is to increase the pipeline of truly culturally competent lactation consultants in the process. And that way we can increase the supply, increase access, and really make some systems level change. So that's all I have for you today. Thank you so much for having me. I'm so honored to be here, and I cannot wait to see what you're doing and will come out of this weekend.
Thank you so much, Andrea, for that perspective, and congrats, of course, on your own startup as well. But really, again, shows that anyone can make a difference with in the innovation space here in healthcare, and it really takes, whether it's your own experience or your own skills to bring to the table. Everyone has something to add to that process. So next, I'll turn it over to Zena to introduce our next speaker.
Yes, so it is my great pleasure to introduce Dr. Jesse Yang. He's our Medical Director of Specialty Population Health Management, as well as our clinical lead for healthcare disparities and a practicing cardiologist at Atrius Health.
So good evening, everyone. My name is Jesse Yang. As Susan has just said, I'm a cardiologist here at Atrius, medical director of specialty pop health, and also associate medical director of quality, safety, and equity. And I wanted to kind of start off, my talk tonight just by telling you about a patient. This is a patient of mine. I'm just going to shorten his name here to Mr. H. So, Mr. H came to me initially for management of his blood pressure, and unfortunately, his blood pressure was poorly controlled when I met him. He was now having chest pain at this point. And further investigation revealed that Mr. H had likely had a heart attack at some point over the course of the last couple of months, and now his heart function was reduced in this setting. And now I found myself trying to pick up the pieces, get Mr. H's blood pressure under control, treat his heart disease in order to prevent his heart attack from potentially progressing to heart failure. And as I looked through Mr. H's chart, and what I saw countless missed primary care visits over the last 5 years. Multiple times where his blood pressure was noted to be high and he didn't show up in follow-up to get his meds adjusted. And Mr. H, like so many patients like him who miss visits and don't follow up, carries a descriptor as non-compliant in our system. There's notes, there's physicians, there's nurses, who say, oh, Mr. H, again, one of our non-compliant patients. And his non-compliance is what's blamed and led to his uncontrolled blood pressure. His non-compliance led to his heart attack. His non-compliance led to his current chest pain and his impending heart failure. But labeling Mr. H as non-compliant is simple. It's easy and it's flawed. Because I can tell you a little bit more about Mr. H. Mr. H has a family and children. Mr. H is the primary breadwinner. Mr. H has been in between jobs for the last few years as has been laid off multiple times. Mr. H works 7 days a week. Mr. H has no control over his hours, and he needed help, and we failed him. Because Mr. H isn't a non-compliant patient. He was a patient at risk because of his social situation, at risk because of his financial situation, and at risk because of his social vulnerability. And it's that social vulnerability that led Mr. H becoming medically at risk. And it's then that medical risk turned into real medical problems and real life-threatening conditions. Mr. H isn't non-compliant. Mr. H is a victim of our system. My goal here today is to challenge you to think about how we can identify and prevent disparities like what happened to Mr. H from happening in the first place. As many of you know, healthcare is reactionary. If you have chest pain and then have a positive stress test, we put a stent in your blocked off artery. If you start losing weight, we get a CT scan and find out that you have colon cancer and start treatment. While our reactionary healthcare system is effective in treating the problem at hand, what it is effective in is preventing the problem in the first place. If that patient with the chest pain had gotten good dietary advice earlier on, or gotten on the right medicines to lower their cholesterol or blood pressure, they never would have developed that plaque buildup in the first place. If that patient with the weight loss had gotten their colonoscopy years earlier when they were supposed to, that tumor they have now would have been a polyp that could have easily been snipped. Just like the earlier medical interventions that could have stopped that heart blockage or found that early cancer, there are social and medical interventions that could have stopped a patient like Mr. H from having a heart attack. The question for us is, can we identify the patients at risk early on? Can we identify the young mother who has food insecurity and provide her with the services she needs before her children show up in the pediatric clinics with malnutrition? Can we identify the middle-aged man with diabetes who's trying to find a job and provide him with the job search assistance before he ends up being unable to pay for his insulin? Too often in healthcare, we find ourselves treating the symptoms and not the root of the problem. When it comes to disparities, that root is multi-tiered, it's multi-layered, it's the product of dozens of insults and barriers from a system that is inherently unfair and racist. So my challenge to you all today is to find those patients suffering from the injustices of our system. Although we may not be able to right the wrongs of society or remove the barriers present, what we can do is try to identify those at risk and provide the assistance to bypass those barriers. What we need to do is find those individuals who need us to act now and not 10 years from now. What we must do is find Mr. H and not let Mr. H, the one that I met, ever happen. Thank you all, good luck, and I appreciate you all so much for working on this very, very important initiative. Thanks, everyone.
Thank you, Dr. Yang. So it is now my pleasure to introduce our next speaker, Dr. Irene Hedden. We at Race to Better Health are so lucky that she's currently serving as a contributing member of the research development team and as a strategic advisor to innovation and collaboration. But beyond that, and perhaps more importantly, she has a full-time job as an assistant professor of Black Health in the Department of Community Health and Prevention at the Drexel Dorns Life School of Public Health. She's a trained social and perinatal epidemiologist, and her research investigates the social and structural determinants of racial and ethnic inequities in adverse pregnancy outcomes, focusing on identifying neighborhood and community factors underlying these inequities and understanding how system science methods can help translate these factors into multi-level interventions to improve Black maternal health outcomes. She received her doctoral degree in epidemiology from the University of California, Berkeley in 2015, and continued on to complete postdoctoral fellowships at UC Berkeley and the Drexel Urban Health Collaborative. She is also a proud alum of MIT, and we're very happy to have her here today.
Well, thank you, Lydia. And that was definitely a mouthful of an introduction, true to my academic roots. So I have a few slides. I think they're embedded in the this group presentation, or Freddie, should I? Oh, excellent. These are my slides. Wonderful. So as Lydia mentioned, the bulk of my work and my training has been embedded in this context of understanding the root causes at a population level of adverse outcomes, particularly for Black American women across a number of different pregnancy outcomes over the course of childbearing. So my goal with this presentation is to give you kind of a 30,000-foot view, a bit of level setting for the insights and the contours of the problems that you'll be solving with these amazing innovative and tech solutions, and hopefully give you seeds of challenges to overcome outside of the problem, but kind of more around the context shaping and scaffolding that problem, the ones that were mentioned in the previous presentations, that will be critical in testing and ensuring that the technologies that are advanced actually respond to and are used by the populations that need them most. So I will dive in. Next slide, please. And because I'm an epidemiologist, I'm mirrored in data and studies all day, I always like to start my presentations with kind of the why of it. And the why is often never in the data, but really in the stories, in the women, in their families and communities that are disproportionately and historically impacted by these disproportionate adverse pregnancy outcomes over time. And I think, in 2017, the investigative journalistic expose that ProPublica put together on lost mothers really reinvigorated and reignited the prioritization of disproportionate impact of maternal mortality for Black women as a national crisis. For me, the stories that I carry with me in doing this work are those of Kira Johnson on the left, Shalon Irving in the middle, and Erica Garner on the far right. Kira, they all come from different walks of life. Kira Johnson was, a lawyer and worked in DC, was connected in that society. Shalon Irving was actually a lieutenant in the public health services, working on solving these complex health disparities problems across the care continuum and the disease continuum over, Black populations' lives. And Erica Garner is the daughter of Eric Garner, who was murdered by police in 2015 with the famous last words of "I can't breathe." All of these women also are joined by the unacceptable similarity that they all passed as a result of complications during pregnancy and childbearing, often that were a result of their voices not being heard and being embedded in a context that does not often recognize their humanity, both at the childbearing window, but over the course of their lives. So these are the stories that really hue the context of, next slide, please, Freddie, the multiple adverse outcomes that occur for Black women over the course of childbearing. So maternal mortality captures the most dire and the most urgent outcome that we want to avoid, but even starting before pregnancy in terms of the 50% higher risk of maternal obesity that Black women face, going on to the 40% higher risk of hypertensive disorder during pregnancy that Black women face. All of that accumulating, of course, within the context of other care criteria, into a 2 times higher risk of severe maternal morbidity events during and after the course of delivery, as well as was mentioned previously in this presentation, or in this session, the 3 to 4 times higher risk of maternal mortality that Black women face. These disparities go on to impact Black infants as well, with them having a 2 times higher risk of low birth weight or small for gestational age, a 50% higher risk of being born early or preterm birth, and a twice higher risk of infant mortality or dying during the first year of birth. And so we can see it's not only at these critical endpoints that we absolutely want to avoid, but it's really this context of adverse disease outcomes, both just prior to, over the course of, and subsequent to the delivery process that really shape the contours of the disproportionate impact of adverse pregnancy outcomes on Black women. Next slide, please. And most critically, for what I think is needed for innovative solutions at the current moment, is the fact that these racial inequities in adverse pregnancy outcomes also impact long-term health trajectories. So here, one of the models that really is at the foundation of my work is the life course model, which was put forward by 2 foundational epidemiologists decades ago. But it really says that it's not only just this critical window of pregnancy that acts as an uncovering event for a lot of subsequent life course events, but it's really also the accumulation of lifelong adversity that's disproportionately distributed between Black and white populations that really kind of is encapsulated both over the life course, uncovered during pregnancy, and then continue to be amplified by our lack of being able to kind of wrap that care system, wrap that contextual system around Black birthing people during and after that kind of window of pregnancy. And so Black women are rather just kind of on a global scale, women who gain too much during pregnancy also have increased odds of midlife obesity. Those odds are increased by 64%. Women experiencing hypertensive disorders during pregnancy also have an increased risk of adverse cardiovascular outcomes, and that risk is increased by 80 to 210%. And furthermore, 70% of women with gestational diabetes go on to develop type 2 diabetes in their lifetime. And so when we're thinking about how we optimize solutions, how do we hack solutions, I think this is a critical contour of the problem that needs to be highlighted in these solutions, especially for disrupting the disparities that impact Black women, both during the childbearing context, as well as over the life course. Next slide, please. And a critical element of this is that, and again, this is from my population epidemiology perspective, but I think is a really critical frustration of both the medical and the public health field, is that knowledge of risk factors has not yielded reduction in inequities. So we've put millions of dollars, huge studies, and really well done studies to identify a whole host of risk factors across the healthcare context, patient characteristic context, clinical factors, sociodemographic factors, and environmental factors. But there's still challenges in the fact that these innovations often don't translate from either clinical context or even public health context to solutions that reduce inequities at the population level. And so to give a real kind of visual implication of this kind of gap, next slide, please. I think these 2 graphs for me really hammer down the problem. And it's the fact that this host of medical and public health research that we've done over the past decades that have identified these risk factors have done an excellent job of reducing these red, blue, and green lines. And these are the population level rates and incidence of maternal mortality on the left and infant mortality on the right. And so as you can see, for Black populations, the total population, and white populations in green on that lowest line, for both maternal mortality and infant mortality, investing in these interventions has reduced population rates. And these end at 2007, but these trends continue on to the current day. But as we've gotten these gains in reducing population level rates of these adverse outcomes, these have often exacerbated the extent of inequities in these outcomes. And it's really innovations to optimize the reductions of this gray and the blue lines that really are the crux of the challenges facing all of us really embedded in solutions for these problems. Next slide, please. And for my work, and a lot of the work of the social epidemiologists that I work with, one of the innovative research approaches that we've been advocating and advancing over the last few decades that have been mentioned in many of the presentations are placing women back into their context. health doesn't happen in a vacuum, as was very clearly articulated in the previous presentation. Women and families are embedded in social relationships, they're embedded in living conditions, they're embedded in neighborhoods and communities, institutions, and economic policies. And further, next slide, please. In considering these contexts, racism is baked into each of these levels in not only kind of separate ways, but in ways that iterate and amplify racism experience across different levels. So what I mean by that is that neighborhood or racism experience in institutional contexts such as employment can actually feed back into shaping the contours of the neighborhood ecosystem that Black populations and Black birthing women are navigating over their life course. So there, you're not just necessarily having this additive factor of racism based off of, say, redlining in the neighborhood context and racism based off of exclusion from job access in the employment context, but you really have these feeding off of each other to recreate racially disparate context, again, in which Black women and Black birthing people are trying to navigate and amplify their health, their pregnancy, healthy pregnancy outcomes. And so in thinking of racism baked into all of these contexts, I do want to give just a plug to just like maybe some kind of seeds of wisdom to cultivate over this kind of hackathon. I know there'll be great ideas, but on the next slide, I really kind of think these are seeds. I want to show seeds of, I think, I guess, light in terms of how do we actually operationalize the fact that women are embedded in context and racism is embedded across all of these contexts into actually effective technological solutions. And one of those has been, advances has been in the context of implicit bias. There have been many kind of health tech and apps that really are driven by the stories of Black women, optimized based off of the use and the context in which Black women will use these applications in order to really call out implicit bias, as well as create kind of structures that can allow women to circumvent the implicit bias that's baked into the system while we're fixing the actual system. So applications such as May, which is like a platform that links Black women and Black birthing people with culturally competent care. It's one of those structures that says, while we're fixing the healthcare system and while we're fixing also the public health system that has racism baked in, how do we link Black women with culturally competent care that reduces the experience of racism across multiple levels? There's also been advances by a team out at UCSF to advance one slide back. Advances in how we even measure, how we even conceptualize what does it mean to measure obstetric racism. And I wanted to highlight this because I think how we define the problem is critical to how we develop technologies to solve that problem. And so these are two kind of, I guess, seeds, breadcrumbs that people can kind of follow as they're kind of getting inspiration to how to kind of move forward innovative solutions for this hackathon around improving outcomes for women in pregnancy during that childbearing window. And I do want to end on my final slide with I guess, a perspective that I always bring to my work. And it's actually that, as Ruha Benjamin, the great sociologist and anthropologist, kind of discusses in her Race After Technology book in much detail, race itself, if we think about it in the way in which it's had a productive life, and not productive in a good sense, but in terms of generating racial inequity in our societies, race itself is a kind of technology. It's one designed to separate, stratify, and sanctify the many forms of injustice experienced by members of racialized groups, and one that people routinely reimagine and redeploy to their own ends. And I think that's critical to how we think about who's using the innovations that we create, how they're being used, and again, how they may reinforce unintentionally the bias that's embedded across different sociological and societal levels. And so from that kind of insight, solutions must acknowledge the historical context that's created these racially biased and racially stratified structures and processes, and solutions must center the lives and knowledge and wisdom of Black birthing people in their communities. Again, themes that have been amplified, and now just put in an additional plug for as you're kind of developing innovative hacks to improving maternal health as critical to the success of those hacks and actually reducing those inequities and actually reducing that gray and that blue line that I presented in previous slides. And so with that, hopefully I've seated you with a lot of insight, also a lot of questions, and I'll hand it back off to Freddie to continue our kickoff.
Thank you so much for that presentation. I think very enlightening to hear from that perspective as well, and to really help provide participants with yet another perspective on some of the issues facing in health equity, especially in women's health and pregnancy. So next we have Dr. David Rowe, who is the Global Chief Medical Officer and Vice President of Healthcare for Microsoft. He's also an adjunct professor at Stanford University, received his MD training at Northwestern, and has completed fellowships, did his internal medicine residency, and then completed fellowships in health services research and infectious disease.
Freddie, it's a pleasure to be here. I know I had an opportunity a couple years back to provide a keynote and also to be a mentor for several folks, and it was an exciting time. Hopefully I'll have an opportunity again, but thanks for inviting me.
So just to get things kicked off, we've heard, from obviously brand new startups that are coming about in this space and trying to, at least teach us about how to innovate in this process. We've heard from more the academic perspective as well. One of the things that I'm curious about your thoughts is, and we alluded a little bit this when Gil Addo was talking as well, was what are some ways in which technology can really help address health equity issues as opposed to potentially further exacerbating those issues?
Yeah, I mean, that's a great question. And in fact, that's always something that we're concerned about, that we may introduce in the process of trying to do good factors that could potentially exacerbate some of those disparities. Telemedicine would probably be the classic example. But I'd like to share with you an example of something that we've been actively engaged in. I personally have found to be very insightful relative to how we can look at the whole health disparity piece. And it relates to the rollout of the vaccinations. When really the vaccinations started rolling out, Microsoft leaned in and started identifying with our partners, and partners being countries and states and other entities, that there were a lot of gaps. Generally speaking, there wasn't a system in place to be able to do mass vaccinations. It was not really possible to do this on an EHR. Generally, most of the EHRs that were trying to do this were getting overloaded and crashing. In fact, what we found is that there had to be a different system set up. So we stood one up. It enabled registration, scheduling, and allowed people to be able to get the vaccinations in these large sites. But what was happening was that not everyone could make it to those sites. And in fact, what we realized is that we had to bring the vaccines to individuals in communities, whether they be in parking lots or churches or other areas that were in underserved areas. And that was, I'll say, the first step of how we were trying to address that. And in many cases, we were surprised that we actually still couldn't get a significant number of individuals vaccinated. And I think that became sort of that realization that we have to go beyond simply just making it accessible. And what we have to start doing is focusing on the human factors. The human factors in this case being a conversation with trusted individuals that have understanding and capability to be able to express why things are important, such as vaccinations, why it's important not only from the societal perspective, but also from the personal perspective. And what we wanted to do is we wanted to have those conversations in the local areas by engaging local community leaders. That's a unusual thing for healthcare and public health to do, because we realized we had to empower individuals in these communities with the knowledge and with the tools. Oftentimes they actually did have the passion to do it, but just not necessarily the tools or the knowledge. And so marrying them with public health and with healthcare organizations in a process where we would actually host events that were not even healthcare related. They were like Cinco de Mayo or Mother's Day or return to school events. But then in the context of those events, we had literally a health fair. And it wasn't just COVID. It was about all the things that were missed during the pandemic. We're talking blood pressure screenings, diabetes screenings. We're talking about cancer screenings, enrolling people into insurance programs. And this process seemed to work very well. In fact, we've had great success already now in the state of Washington. We rolled this out specifically in the Latinx populations. Then we started moving towards California, engaging more partners in this process in predominantly migrant farm worker communities, and then continue to move to Georgia, where in one of the areas, Clarkston's considered one of the most ethnically diverse in the United States. Big challenges around language and also issues around, just immigration concerns. And then we had an outreach from the state of Mississippi, which had the lowest vaccination rates in the country and the highest mortality rates. And we've now been able to have these events, and some of the key success metrics is that we've been able to get about, in these events, typically 400 to 600 individuals. A third of them are vaccinated. And then in addition to the vaccinations, a whole series of other types of health services have been delivered. And what we have found is that on the second event, where they would oftentimes come back, there would be about 2 to 3 times as more individuals that would come back because the family and the friends were being brought in by the original individuals. And so what does this teach us? This taught us a few key lessons. Well, first and foremost, we oftentimes think that simply providing the technology is good enough. Not so. You needed to actually make it accessible, easily accessible. And that wasn't good enough, because then we had to go to the next step of actually finding ways that we can empower the individuals around consumer or around engagement and addressing the questions and the concerns. And I think that's really what the playbook is. It's about trying to understand how we can apply technology in all these different capacities, but leveraging the power of the communities to be able to have those conversations and be able to provide the infrastructure needed to make this scalable.
And you brought a really good point around how do you build that trust. Can you talk maybe about kind of where some of those challenges that you've seen and how to best overcome that challenge of building that trust with those communities, especially, like you said, the communities that often distrust the healthcare system in a lot of ways?
Yeah, and it's a great question. And there's a lot of reasons for that distrust, if you look just at the history. But what we were looking at was not so much that it was coming from the healthcare provider or from any other entity that was external to the community. It was coming from local trusted leaders. These oftentimes were folks that we hadn't even anticipated. So for instance, when we were in Mississippi, they told us in the populations we were looking for, go to the beauticians, go to the barbershops. That was something that we hadn't even thought of, but we followed their direction. When we were in California with the migrant farm workers, they said, you've got to go to the employers. These are the farmers that are dedicated to trying to ensure that the safety of the individuals are met. But at the same time, they're going to give time off. And they're also going to bring in the local community leaders. And so what we really wanted to do is we had to identify at a local level who are the individuals that are not only the people who can influence, but that can also inform. And then what we did is we had to marry them up with this trained healthcare specialist in the public health sector, because if it's just people talking about things, it's not going to be enough. You actually have to have the combination of both the healthcare and public health. And that's another key learning, that if we're looking to solve these complex problems, it won't just be one sector that solves it. It's going to be through public-private partnerships.
And it's really important point, especially the engagement of other sectors, especially in the space of equity, where a lot of the underlying issues aren't necessarily unique to healthcare itself, but really societal.
Absolutely.
Sense. So, in thinking about this hackathon and what the participants are, listening to all the speakers tonight, what are some key ways where sort of a bottoms-up approach to innovating into development of solutions compared to some of the top-down type of initiatives you've seen so far that could really have a meaningful impact in tackling health equity issues?
Yeah, these type of hackathons are well suited for addressing these type of issues. And I'll tell you a few reasons why. Typically, when we look at healthcare innovation, oftentimes the challenge is that it's based on clinical workflow. You've got to figure out some way to integrate it into an electronic health record, or you have to figure out some way to pull the data out. We're talking about people living in their homes, on the streets, on the go, outside of an EHR system. That's what we know. The people, everyone here knows people, and those people, we know the challenges. We have a deeper understanding of what the challenges are. We know how to be able to overcome them, but what we have to figure out is how can we work together to be able to build a system that's sustainable, that allows us to be able to address that. And that actually occurs outside of healthcare. What we have to do then is figure out how that process of fixing that problem can then be brought back into healthcare so that it can be delivered through a proper healthcare delivery mechanism so that individuals will have consistent care that allows us to be able to address those issues. That's the challenge. It's actually an outside-in approach as opposed to an inside-out. And that's why the individuals here within this hackathon are probably going to have a lot of the answers that we need, but there'll probably need to be some coordination to figure out how those solutions will then be brought back into a complex healthcare system or a public health infrastructure.
I guess, from that perspective, as these teams start to develop potential new solutions, what advice do you have for helping them think about, okay, what's that next step in terms of either integrating into what's existing or scaling into what's existing, right? Or being that external innovation that comes into the system.
Well, I think one of the things you're going to have to think about is, first and foremost, is this something that we think is going to make a meaningful difference? A lot of times we see innovations that are, I'll say, nice to haves. There's a lot of effort required. But if we think this is going to make a significant impact, then do we have to ask, do we have all the right partners involved? A lot of times we forget, that this, and this happens all the time, whether it's on the healthcare side or external to that. If we don't have all the healthcare or the key stakeholders and we haven't thought about that process, that's not going to be a sustainable process. And lastly, and this is an area that we think a lot about, the data. There is data behind all of this. If I think about the vaccination, people oftentimes ask, well, what was Microsoft doing as part of this? I mean, you've got communities that are all engaged with public health. Well, at the end of the day, the data is now being captured. It has to be brought from the community into the electronic health record or into the state immunization registry. It has to be secured. There has to be a process so that the second follow-up is made. And so don't forget about the data. The data is a critical piece. It's an infrastructure piece that allows us to be able to create that sustainability. So you've got the right people, you've got the right infrastructure, but then you've got the right data platform that supports it.
No, that was some great advice, and I really appreciate you talking to our participants today, Dr. Ru. That will move on to our next speaker, Dr. Charles Centello, who is the professor at Rutgers University and also was formerly the Martin Luther King Scholar at MIT.
Thanks so much, Freddie. I appreciate it. It's wonderful to be here. So anyway, thank you for the opportunity, Freddie, and I commend the attendees here to work on such important and pressing issues. I'm going to talk just briefly tonight about persistent challenges to address health equity, specifically around social determinants of health and how they could be used and should be used to inform clinical decisions. So thank you for that wonderful introduction, Freddie. So I want to just start really quickly. What is health equity? At a high level, it's differences in health status between groups, and these groups can be cut in many, many different ways. And certainly in the past year and a half or so, inequity has gotten much more attention, and I think that that's a good thing. Illumination of these persistent structural issues that we know result in health inequities will welcome additional novel approaches to addressing them. And events like this is certainly a great way to sort of share ideas and put a dent in some of these persistent issues. The pandemic obviously has made sort of racial inequities front page news. And that's something that is, again, important, and I applaud it, and the tent is a big one. And I welcome other disciplines and other people to become involved to try to address some of these persistent issues. Just some really quick facts that I like to sort of ground and have a common understanding. Infant mortality rates for Blacks is more than twice that of whites. And in Milwaukee, which is an interesting city to look at health inequities, infants born to low SES households are 3.5 times more likely to die in the first years of life. And there are many different statistics that illuminate these racial inequities. When did racial inequity, health inequity emerge, and why? Well, racial differences in healthcare are present at the very inception of health records being kept in the United States. Up until and through the Civil War in 1861, physicians debated whether already well-known racial inequities or racial disparities in health were due to biology, because simply Blacks were just genetically inferior, or social factors, because many Blacks were enslaved and all lived in a society steeped in white supremacy, one in which Blacks' minds, souls, and spirits just didn't matter as much as white people's. At that time, the debate was deeply rooted in politics, as anti-slavery physicians, which included the first generation of Black doctors, at least in this country, argued that social factors were the drivers. These factors were, at the time, defined by the need for cheap labor, and those conditions were what determined both the progression of disease and the health status of enslaved Blacks, mostly in the South, and impoverished Blacks in the North. The biology versus social debate about the explanation for racial health disparities persisted until W.E.B. Du Bois' seminal work in 1899, The Philadelphia Negro. Du Bois contrasted the biological point of view in his observation that, quote, social advancements and vastly different living conditions under which Blacks and whites lived were the drivers of racial health inequities. Du Bois, the sociologist, argued that the causes of racial differences in health were multifactorial. They were primarily social. I submit that Du Bois is as significant to health equity research as the London physician John Snow is to public health. As many of you know, Snow's research found that cholera was spreading through contaminated water. This is a picture of the Broad Street pump, which many of us in public health are well familiar with, which conflicted with the scientific truth at the time, which was that cholera spread through the air. Another example, or an example of how science, quote unquote, hadn't quite reconciled the facts quite yet. But back to Du Bois. He went further, I posit further than anyone up to this point, in making the argument for social factors. He observed the apathy to the disparities. And at times, I think we still don't care quite enough. We still don't behave often enough as if Black and brown lives matter, or matter as much as other lives. Du Bois talked about social advancements and vastly different living conditions. He did not use the term social determinants of health, but as we'll see, he was talking essentially about the same thing. But for the purposes of our discussion tonight, I want to point us to a particularly poignant quote from the Philadelphia Negro. The most difficult social problem in the matter of Negro health is a peculiar attitude of the nation towards the well-being of the race. There have been few other cases in the history of the civilized peoples where human suffering has been viewed with such peculiar indifference. I have it bolded for emphasis. In fact, social factors have been identified for quite some time. Social conditions' effect on health outcomes was described in the mid-1800s. A Prussian doctor described that hunger, illiteracy, depression, and poverty were factors in typhus outbreaks in the coal-rich region that is now Poland. So in the US, for over 100 years, social factors, again, as I mentioned, social determinants of health, which some of us, of course, are familiar with, not genetic factors as was speculated, has been described as primarily causal factors, or the primary causal factors for racial health disparities. Things like financial strain, environmental factors, access to healthcare, access to safe physical activity, access to healthy foods. So it's important to understand the context for which and the long runway of research that supports the impact of social determinants of health. Again, many of us are probably familiar with these factors. Again, Du Bois observed social advancements in vastly different living conditions, which we see across the 5 central social determinants of health: economic stability, education, social and community context, health and healthcare access, and neighborhood and built environment. I want to emphasize here that social determinants of health are not like gravity, a kind of natural law that just sort of happens. These drivers are the result of institutions that create and sustain them, These institutions are populated by individuals who either actively make decisions to maintain inequity or passively maintain inequity by simply looking the other way, by not caring quite enough for the least of these. When I first started studying health inequity around the mid-2000s, like many, I thought the healthcare system was broken. Maybe not. Perhaps it's like the criminal justice system. There are researchers who suggest the criminal justice system is not broken. It's operating just as it's designed to operate. According to the Federal Interagency Reentry Council, the cost of imprisonment in jail in the past 20 years has grown at a faster rate than nearly any other state budget item. It costs about $80 a day to house an inmate, and the United States spends in excess of $68 billion a year on corrections, federal, state, and local. I point this out because we should never assume that we're all united in our desire to eliminate racial inequity. Social determinants impact everyone, but not everyone equally. Social determinants impact specific groups more so, disproportionately, older adults and children. Children, especially critical, given that their physical, social, and emotional capabilities develop early in life, and they provide a foundation for life course, health, and well-being. These nature-nurture interactions occurring early in childhood development can hold impact far across the lifespan. And systematic racism and colorism are types of determinants which do not impact groups equally. Social factors, these determinants, are the primary causes of racial inequity for common conditions, and as we know now, COVID-19 outcomes. Racial inequities for COVID outcomes emerged early in the pandemic, and various risk factors were explored. Again, the nature or the biological versus social argument or debate emerged early in the pandemic, where there was speculation and research around were there genetic factors that predispose certain populations to infection, to hospitalization, to death. We found that that is largely social factors are at play in these inequities. Primary risk factors, like greater proportion of essential jobs, these essential workers, the number of people in a household, etc. So very early, I intentionally have these dates here. These are papers published in 2020. Risk of infection, hospitalization, and death mirrored persistent racial inequity for common chronic conditions like heart disease, diabetes, and cancers. And as we've seen, just as medical care alone has not eradicated racial inequities in health, medical care alone will not result in racial inequity for COVID-19 and other health conditions. I want to talk just briefly about how we perceive structural inequities. What are they? Structural inequities, systematic disadvantage of one social group compared to other groups with whom they coexist, that are deeply embedded in the fabric of society. The US narrative, interestingly enough, draws this distinction between the past, say, pre-1950s, and the present. What's the past? What happened? What happened, at least in this country? The narrative asserts that until the 1950s, US history was impacted and shaped by slavery, American Indian removal, lack of rights for women, Jim Crow segregation, period of nativist restrictions on immigration and waves of mass deportation of Hispanic immigrants, eugenics, the internment of Japanese Americans, Chinese exclusion policies, criminalization of homosexual acts, and of course, much more. After the 1950s, civil rights, women's liberation, gay rights, disability rights, movements and their aftermaths may contribute to a narrative that social, political, and cultural institutions have made wonderful progress towards equity, diversity, and inclusion. Highlights include of the many signs of progress: the Civil Rights Act of 1964, Voting Rights Act of 65, Fair Housing Act, Title IX, educational amendments passed in 72, Americans with Disabilities Act, and of course, the Patient Protection and Affordable Care Act. These are, in fact, changes. However, as discussed, racial inequity due to structural factors suggests that the distinction between the past and the present is not so clear. It's vital also to understand perceptions given the persistent inequities, given, as was stated earlier in an earlier speaker, the disproportionate mistrust, and of course, the proliferation of mis, mal, and disinformation. Early in the pandemic, I speculated that social determinants of health, I and other health equity researchers, combined with the dynamic of people of color having high medical mistrust and this proliferation of mis, mal, and disinformation may be exacerbated by existing perceptions based on historical and contemporary factors. And what we found early is that COVID-19 vaccine perceptions, existing perceived discrimination in healthcare actually plays a role in health outcomes, because these in fact are among social determinants. Technologists have great potential to improve the collection and use of social determinants information to inform clinical decisions. However, I must caution us, those of us who are enamored with and work with technology, that the developers of health information technology, like me, may actually exacerbate inequity. Intervention-generated equality, IGI, is a glaring issue. Health information technology interventions may disproportionately benefit more advantaged people. And inequalities are observed at each stage of intervention: efficacy, access, uptake, lower SES. So these social factors play a role in technology uptake, technology use. And anyone that has tried to use a patient portal on a phone can probably relate to what it's like for people, those of us who must access or do primarily access health information via or access technology, access the web through the technology of the phone. So technological interventions do work, but they may work better for those who are already better off. And this is a persistent issue for all researchers and developers of health information technology. And I deeply encourage the participants of this weekend's hackathon to take a close look at our historical factors, how long we've known causes of health inequity, and the role of technology, just to ensure that we're not exacerbating existing known issues. And with that, I like this graphic, which pulls together the social determinants of health, and I welcome comments and discussion.
Thank you so much, Dr. Centeno. It was really great talk about social determinants of health and the importance of really taking into account all of those components as people think about health inequities and the issues that are underlying it. So we're going to move on to our next speaker. We'll have a general Q&A for all the speakers at the end. So if participants want to start posting their questions in the Q&A, we can start monitoring those as well. So next we have Dr. Daryl Gray, who is the inaugural Chief Health Equity Officer for Anthem, who just started a few months back in August. Prior to Anthem, he was an associate professor of medicine at The Ohio State University, was a practicing gastroenterologist there with Ohio State, as well as deputy director of the Center for Cancer Health Equity at Ohio State's Comprehensive Cancer Center. So welcome, Dr. Gray.
Thanks so much, Freddie, for having me. Really excited to be here and join this illustrious panel of speakers.
So I guess one of my first questions to you is, there's been a lot of attempts to try and address these issues in the past by different parts of the healthcare system, inside and outside. But what do you think have been those the biggest roadblocks or challenges for innovating new solutions, whether is it at the ideation level, creation level, is that the implementation level, scaling level, or is it sustainability issues?
Thanks for that question. I think, Freddie, honestly, I think the issue and the problem, the barrier has largely stemmed from us, in that we try to center our own ideas and then take those ideas into the communities that need it most, without actually centering at the margins, meaning, amplifying the voices and the ideas of the community. And I can name instance after instance where that has failed us. And so it's really up to us to really center at the margins and really amplify the voices of our community, but also share power and resources with those within our community, because that's where those who are most proximal to the problem, those who are most proximal to the inequity, are most likely to have the solutions. And I think we have to do a better job. And the truth of the matter is, and I think some of our prior speakers alluded to this as well, is that we, whether it be researchers, whether it be physicians, we honestly haven't been great trusted brokers in the past. And so it's no surprise that as we're trying to develop solutions, whether it's amidst the COVID-19 pandemic or otherwise, that we aren't trusted and people don't just jump at the bit to accept what we want to give them. And so I think it's really up to us. And I really applaud our prior speakers for really highlighting this, that we must engage our communities. Community engagement is much different than community outreach. Gone are the days when we should pat ourselves on the back for doing health fairs where we check blood pressures and do finger sticks for blood glucose. No, community engagement means that we really work with our community in co-design. So if we are co-designing with our community, we are more likely to be able to aptly address some of the inequities that we see in our community.
I think, as you said, many of our speakers have brought up the whole point of ensuring that we have the people to which we're developing solutions for at the table from the very beginning, right? At the problem definition and the solution development. But oftentimes these populations are also the hardest to reach. And it's not simple. I mean, distress is certainly part of it. But what are some ways that, especially if we think about the participants during this hackathon, one of the things we always tell them is, go out there, go talk to people, talk to people in terms of testing and validating your thought process, your hypotheses, your ideas. But how do you reach those individuals?
It takes me back, early in my medical career when I was actively practicing, actually in training, someone said a quote that has really stuck with me. And that's, people don't care how much you know until they know how much you care. And so really, if we're going to reach different populations, that it's not necessarily that they're hard to reach, but perhaps we haven't been trusted enough, and rightfully so. We haven't earned that trust for us to stay connected with them. I think, part of it is we have to take off our white coats those of us who are clinicians. Those of us who are in the lab, whether a dry lab or wet lab, we have to step outside of our laboratory and spend time in the community. And one of the things that when we do engagement, it's not for always the intent of what our study is or what our project is. If we do just that, it's kind of like helicopter research, meaning we fly in to do our study, to do our survey, and never to be seen again in the community. That's not what the community wants, and that's not what they need. They need someone to be there, to understand them, to know them, to work with them. And so I think if we are really going to be genuine and authentic in this, we have to be in the community for whatever they want. So that may be in conflict or a competing interest or priority to what we have for our research agenda. But that's part of relationship. You may have to attend a meeting, a town hall that has nothing to do with what your research agenda is, but that's how relationship is built. And so it takes time. And a lot of times we think about, well, we don't necessarily always have the time, but it does take time to build relationship. And it's through relationship that we can make change. And the other point is, a lot of times when we go to the community, we don't go to the community speaking a language that they readily understand or speak. And so a lot of times we have to throw our jargon aside and come to conversations authentic in a way that they can understand. And part of that, maybe it's not us being the speaker, but maybe we also use trusted brokers, community-based organizations, churches being another example, where people are trust the authority figures in that setting, and maybe they can be the person to speak on our behalf. But I think we have to leverage relationships in a way that we have not in the past, because what's been talked about today as far as mistrust is very real.
You bring up a couple of points. One is, really trying to figure out who are those individuals that are the trusted brokers that people more feel either trust, more comfortable with, associated with. I mean, we see that, of course, even for looking at one of the challenges for this hackathon and diversification of our clinical workforce, right? We're trying to find ways to better, represent who our patients are so that they can better connect and get better care. I guess to that point too is, one topic that hasn't really been hit on tonight yet has been around the issue of intersectionality, right? How do we start thinking about health equity and, there's at the population level, public health level, but then now at the individual level or subpopulation levels where, at what point are we treating an individual versus, a population?
Yeah, I so appreciate that. And I'll put it in perspective of who I am and why I think it's even important beyond the individual level. So what others may not have gotten in the introduction, the nice introduction you gave, Freddie, is that I'm a believer. I am a husband of 11 years. I'm a father to 3 kids, 3 little kids, and a 4th on the way in February. I am a physician, a community advocate, a researcher, and all of those things inform who I am, but also my perspective, right? So those things have afforded me to have social networks, so that social isolation, for example, is not a huge issue for me. It's allowed me to be able to live in a neighborhood where my kids have access to green space and safe sidewalks. It's allowed me to live in a place where I don't have to worry about dilapidated, housing, for example, that my neighbors may be exposed to or have the health consequences of as a result of living in that. And so I recognize that I bring privilege because of these experiences that I've had. But I also recognize that there are many, even within arm's reach of my family, that do not have the same privilege or come up from very different lived experiences. I also understand that even though I'm Black, I'm a Black male, I can't necessarily just go into every Black audience, for example, and feel as though just because I'm Black that I will automatically be accepted. No, that's not the case. And that's a misconception, because I think, part of it is people may say, well, you're Dr. Gray, you come with a doctorate, right? And so you don't necessarily see through the same lens that we see through. And so that's again why number one, we have to understand each other and each other's experiences, but we can't make presumptions, just like going into the community and presuming that because you're from the community that you'll be accepted by that community for whatever your agenda is. So as we think about intersectionality, and particularly for those innovators out there, I think we have to do a better job of understanding and capturing what that intersectionality is. Prior speakers have talked about social determinants of health. Others may be familiar with language like health-related social needs. That's a gap. Capturing actually, as we think about patients, so we think about just people in our communities, being able to understand how we can better capture that information so that we can tailor data-driven, community-engaged solutions for these populations that are most vulnerable and most need our assistance in kind of closing these inequities that we're seeing in our environment. But I think you bring up an outstanding point that we need to do a better job of understanding intersectionality. I'll tell you, from the bench, lab bench, to the bedside, and certainly in the community.
In your opinion, I mean, in the health equity space, obviously, there's no shortage of problems at hand. Do you think there are, in terms of inspiring our participants, should they be reaching out for sort of the really high, goals and problems, or do you think there are low-hanging fruits that can easily make a meaningful impact that they should be tackling?
I would say, Freddie, it's not either or, but it's a both and. I think we start, where you are, and maybe even it might not be trying to develop a small solution. It may just be working on yourself. And I'm not saying that lightly. I mean, it's understanding and identifying what our own biases are that are preventing us from having a significant impact or perpetuating inequities. And I think that's part of education. So it could be starting with education, not only of ourselves, but our peers and our coworkers and frankly, some of our family members, right? But I do think there are large problems that need to be tackled. I think food insecurity needs to be tackled. Homelessness needs to be tackled. Income inequality needs to be tackled. And frankly, even one of the most preeminent social determinants of health, racism, needs to be tackled. And I think that there are many people who are outstandingly brilliant in this hackathon who can help to contribute to making solutions to eliminate those things. And certainly we see digital solutions that are trying to do just that. I was on a call with someone from Bento recently, and their kind of food insecurity solution. So there are many people who are thinking about these huge problems, but also they're trying to think about at the individual level. And I think that's what we have to do. What can we do as an individual within our own networks to tackle these big problems?
Yeah. One of the things that came up during the health conference that, the panel you were on really spoke to was, how do you think about building equity into every process or everything that you do, right? It's, we touch a little bit on that throughout this evening in terms of thinking about, how do we ensure technology doesn't further widen the gap in inequities, right? For the activities that we do, or even the process that we are doing this hackathon or this problem solving. Can you speak a little bit more to that?
Yeah. Yeah, I think, and certainly since I started my role at Anthem, what I see my job is ensuring that health equity is everyone's business. It's not the business of one chief health equity officer, Daryl Gray, but it's everybody seeing what their role is within the organization, no matter what they do. And so part of that is equity by design. It's certainly for those of us who are in different, whether you're in academia, whether you're in the private sector, whatever you do, you're tuned into this hackathon, know that you have a role to play, and it's everyone's business. We have to make sure that it's equity by design in all that we do. So maybe it's on your team asking the tough questions of, maybe you're developing a startup, or maybe you are going to contract with a startup, and it's asking the tough questions of, who will this technology touch and who will this technology not touch? How do we get community buy-in into this tech solution? What are the potential downstream poor outcomes that may come as a result of this? Are there opportunities to exacerbate disparities with this technology that I'm developing? Am I introducing bias into this system? And certainly, I think someone highlighted this earlier, but certainly there's bias in AI, artificial intelligence, and because we bring our own biases into things that we develop. And so we have to start asking the really tough questions at the micro level, so that once we get to the macro level, when the solution is developed, we don't look back and say, oh, this did exacerbate. No, we have to put equity in design of everything we do, from development to research, to then dissemination of that knowledge. And so that's part of what I've been trying to do and continue to do with our team at Anthem, is ensure that as we're going on this journey, we have a mission to improve the health of humanity. We have to do it through an equity lens, whether it's our digital and tech teams, whether it's our commercial product developers, whether it's us in community health, in our health outcomes organization. We have to make sure it's everybody's business and everybody's job, but that also we are one band, one sound. This is bringing up my Ohio State days, one band, one sound, and advancing toward that goal.
Thank you so much, Dr. Gray, for your insights. I think it's a perfect way to end at least our series of speakers. I'd like to invite all our other speakers who are still on to join us in answering some of the Q&As that we have here. So I know there's some earlier that I know Dr. Hinton had answered some of it in the chat. I don't know if you want to pick one of the two questions that you already addressed in the chat, or if you want to.
I can add a little bit to a long-winded answer that I gave. To especially
repeat the question quickly.
Yeah, I'll restate the question. It was really around for the breastfeeding context, the question was presumably, and is this the wrong presumption? For thousands of years, human beings only had breastfeeding as an option to raise a child, and they thrived without help. What happened to change this so that in the modern world, assistance is needed? And I think this is an incredible time, or a question that can highlight many of the things that have been bubbling kind of through thread to many of these conversations, whether it's from the structural policies, that intersectional lens, and the fact of the lack of voices of women in general in creating the policies that dictate the autonomy over their own bodies, as well as specifically for at the intersections of Black women and the birthing context in low income settings. And I think there's like there's many things I will say for people who want a deeper dive. There's many excellent books. A foundational one is Killing the Black Body by Dorothy Roberts, that I think really links kind of the context that's structurally constrained women's ability to breastfeed when it's the appropriate decision for them, as well as to wrap around those helps that were talked about in the previous presentation of supporting them with IBCLCs rather than sending them home with formula. So at the root, I'll say many of the constraints that women are faced with now are the fact that Medicaid policies, a lot of healthcare policies actually reimburse sending, especially low-income Black birthing women, sending them home with formula. There was a whole campaign in which formula was put forth as the nutritional advancing of the future, as a way to develop and advance the health of Black babies, which due to historical racism have been chronically seen as inherently, I don't want to say disease, because I will say, like, we often take such a kind of deficits focus lens toward talking about these contexts. But based off of the history of scientific racism, basically Black babies were just seen as inherently behind the starting point. And so formula was actually promoted as a way of the future, right? Again, a technology to advance the future. And so through those processes, that was actually incentivized, and thus breastfeeding, which is already, as was stated before, it's really hard. We really don't talk about how, it's just really hard. There's a narrative around you just kind of like, I'm hoping everybody will, I'm in reproductive health spaces, and, slap a baby on the boob and it just takes, right? And that is not what happens. There's a lot of pain, there's a lot of adjustment, there's a lot of sleepless nights. So it's already a complex context. And when we're incentivizing moving away from those contexts by giving formula, when you're up at night, your job isn't supporting, breastfeeding. You really just need a little bit of sleep and the baby to sleep. And it's been touted as like this nutritional advance. That's really when the culture of formula feeding, especially for disproportionately Black women and women of color and low-income women, really became embedded in a structure. So, right, that's where we go from just like what's perceived as like a natural process, which again, there's a lot of caveats around that natural process. We're also birthing in more interconnected communities where you weren't alone without the connection of your mom, your aunt, or someone else who could be like, this is how to help you out. But we're also within a context that actually amplifies and disincentivizes breastfeeding is disproportionately for Black women and women of color and low-income women. So that's nuances of it. Really, I think there's a deep dive in Killing the Black Body that kind of walks through the technologies that have been advanced to disincentivize breastfeeding over time.
Irene, can I just chime in? I just want to thank you for sharing that. Even just how you mentioned how, it's natural, but it's still difficult. I watch my own wife, like I said, we have 3 kids and a 4th on the way, and breastfeeding is not easy. And so albeit it may be natural, it is not easy. Not all babies take initially, and not all mommies take initially. And it's difficult. And we have to face that reality too, and better support our moms in breastfeeding. So thank you for that.
So we have a question here around, whether community concerns about social distancing may have also served as a barrier. Mostly referring to health screening events, if they're held outdoors in, say, rainy Washington State. I think kind of a lot of the new barriers that came up during the COVID-19 pandemic, and how do you, will we ever get away from those? How do we address those? Dr. Santiago, you want to take this
Oh,
one?
was that for me? I'm sorry, Freddie. Yeah, I think that the social distancing guidelines and the fallout from them, I think, is going to be with us for some time. And I just want to, before we kind of jump into like the impact on health fairs and these events where we wanted to get and still want to get people engaged with their health, I think it's also important to understand that for many of us, vocationally, it was difficult to social distance. These essential workers that were out. I have a good friend of mine from junior high school, who's a letter carrier, and he's been a mailman for years. And I remember talking to him in the late spring of 2020, and I had many times before. He's got his earbuds in, whatever, and I'm like, "Where are you, Troy?" He goes, "I'm delivering the mail." I said, "What? You're out there?" And he said, "Yeah." And it struck me, and I actually invited him to a couple of talks, that for many of us, me included, it was super easy to just A, keep my job, and B, to just go remote and sit in this room and work. Yeah, there was an adjustment, but I didn't have to go out. I didn't have to go out to make a living. And I think that when we, and all of us, I think, are potentially at risk of being insensitive to other people's experiences and other people's options and choices, is that the simple social distancing, keep your distance, when people are living 3 generations in a home, is very difficult. So I think as we continue to open up, and by the way, I've been reading a lot about medical historians and how it's comparatively easy to determine the beginning of a pandemic compared to determining the end of a pandemic. That's a far more complex threshold to try to determine. But as we work through and as we continue to hopefully open up safely, it's really important for us to understand that not only do social distancing, sort of the sort of rules and how to enforce them and how to encourage people to be knowledgeable of them and to respect them, it's also important to understand that we should meet people where they are and understand that both logistically, in terms of the ease of distancing, either vocationally or because of their living situation, might not be as simple as a snap of the fingers, as many of us for whom it's true, as well as just emotionally and their perceptions of what these guidelines are for, why are they applying to them, and are they applying to them equally? And I think it's important for all of us to understand that these guidelines are not received equally by all of us for various reasons.
Great. I know there's a lot more questions, but we've been running a little bit behind time. So I'd like to actually end it with a round robin question for all of our speakers. One is basically, we've heard a lot about the problems, we've heard a lot of the issues, the complexities that are involved, but perhaps, is there an example of a good successful innovation that you've seen that you can direct participants to and say, here's, a good example. And then secondly, what is that one nugget that you want, a piece of advice or tip that you want to leave participants with as we end tonight, keynote speakers? I don't know who wants to start, but.
I'll start us off, Freddie. Again, thank you, Freddie, the entire team that helped to put this together. This is amazing. Thank you to my fellow panelists. Y'all are incredible. I'm trying to be like y'all when I grow up. No, truly, I'll start with the latter question and go to the former. The latter in kind of a nugget. And I'll put it, one of my Morehouse brothers said this, Sean King, at he and I were giving a talk at a Black men's event in Akron, Ohio, a couple of years ago. And he said this quote that has really stuck with me, because I would spend paragraphs trying to tell this to my mentees, but he said in one sentence, he said, "Do the thing that makes you come alive to impact the issue that breaks your heart. Do the thing that makes you come alive to impact the issue that breaks your heart." So for me, health inequities break my heart. The drivers that lead to those health inequities break my heart. So I go at it with all my might to change that, and to change that in the system, and try to influence others and organizations to do the same. And so as I think about, to your kind of former question around, have I seen examples of where someone has gotten it right? Yeah, there certainly are, innovations that are coming about through startups or existing organizations where they have point solutions. And I think a lot of those are great. I think we do have to do a better job of really engaging with our community and understanding their needs. I'll leave it with this example. We recently at Anthem did this community-based study called What's Driving Our Health. And I believe that website, don't quote me, and I should know this, but it's what'sdrivingourhealth.com or what'sdrivingourhealth.org. And we found out that most of the community that we surveyed had no idea what social drivers of health or social determinants of health mean, and what it means to them and how it influences their health. This is literally about 50% of the people. And so I think, but interestingly, who those were who knew more about social drivers of health? Communities of color. They were very well able to understand about how that linked to their health. So I think we have to educate our communities more about health inequities, about drivers of health that lead to those health inequities, and then leverage their brain trust, leverage their brain power to bring solutions to those very communities. And I'll stop there.
And actually, can I jump in? Because I think one of the solutions that is on top of mind for me built off of that, because my work is kind of right at that intersection of what are those solutions and how do we amplify them? And, one of the things that so I'm in Philadelphia, Pennsylvania, predominantly Black city of Du Bois and the Philadelphia Negro, which I also put in the chat as a shout out as a epidemiologist and the health equity geographer. He also was one of the foundational health equity geographers, really mapping out in the 7th Ward the distributions and determinants of disease. So I always got to do a shout out. But one of the things that I really brought me to Philly and has kept this work really grounded, honestly, in the community and in women is the city's willingness and ability to reimagine how they're using funds from different federal sources to amplify the solutions that women, birthing communities are experiencing, right? So to get a little bit of techie, there's a large Head Start grant that cities get to coordinate care for and kind of like the early and kind of support programs to address these social determinants and care determinants of outcomes for birthing moms and for those kind of first few years of life, right? A lot of times different, healthcare organizations, the city all get their siloed grants and do their siloed programs. In Philadelphia, basically this group called the Community Action Network, which was here when I came here, has been doing really excellent work in seeding this change, decided to come together and say, how can we amplify not only our funds, but our funds to serve as a mini incubator to the solutions that women want. So basically, it was a community engaged, community-based participatory research project, amplifying needs such as like connection to care, connection to culturally competent care, that is now producing those products of an actual centralized referral system. So women aren't going to 5, 10, 15, 20 different referrers to wrap care around them, while we, with privilege, dismantle the structures that constrain their life, but at least getting kind of a centralized referral service that can take the burden off of them of proving their need, which often is how they feel, and going to all of these different, social needs, social resources to, again, wrap around structures that weren't made for them in the first place. And that's one solution that came from the community that's now being amplified. One thing I want to highlight is that while innovation can happen quickly, the scale and magnitude of change that we're looking to basically the ship that we're looking to turn is very large. So I think we also need to have some kind of level setting with how quickly we think change is going to happen and how we can reimagine the metrics for progress so that we're not trying to, basically discount these initiatives, especially those that are trying to change structural racism, because they don't have like a 20% change in disparities in 3 years. Like that's just not how it works. But there are seeds of what needs to be cultivated to amplify that. So I think, and that was kind of talked about in it is past my dinner time, so I'm blanking on names, but the presentation around like the seed of that company was seeded eight years ago, right? If we think on those timescales for how we invest in, cultivate, and reinforce the success mechanisms around the innovations to dismantle structural racism in healthcare, especially for me in women's and pregnancy health, I think that's kind of like a seed or a nugget of wisdom that I kind of impart to people as they're going on this journey.
Dr. Yang?
And I'll just, oh, sorry.
No, go for it, Charles. Go for it.
I was just going to just quickly, I just tie up some of the what the previous speakers had said. One of the sort of concluding remarks about what works well. I can't talk about a specific project without being horribly biased, so I'll be more general. But I think going to communities and establishing and nurturing reciprocal, persistent relationships is a ticket to better work, better solutions, better research, better translational research, because these communities, however you want to define them, have rich perspectives on what works for them and what doesn't work for them. And when those community-based partnerships with researchers like me and many others, when those click, insights happen that can be hugely beneficial, at least on smaller scales. I'm still trying to figure out how to scale some of them, but designing for diversity is I think a phrase that we heard earlier, and that is there's so much value in that. So what I would encourage our attendees to think about is to do what a nurse taught me several years ago, which she called go to the Genba. Go to the Genba, go Genba. That's a term that originally came out of lean manufacturing. But the point is that the Genba is where things happen. The Genba is where, say on a shop floor, where parts are made or where components are assembled. And for me, in health equity work, the Genba is the community. So go to the community, engage in reciprocal, persistent relationships, and do that to incorporate no matter what kind of technology or design or system that you may be conceiving, but the notion of designing for diversity. And what I did is I went and I looked, in concluding my remarks, I went and made sure I had this right. So designing for diversity is a philosophy that encourages us to consider how size, shape, age, gender, sexuality, ethnicity, education levels, income, spoken languages, culture and customs, and even diets shape the way we interact with the world. And I'll put that in the chat.
I appreciate that, Charles. And I just kind of want to build on also what some of these amazing speakers have, said over the last 2 hours. And one of the things that I really liked, and I just really want to emphasize in terms of an effective strategy for building towards equity, is something that Daryl was talking about earlier. And that point is the fact that, again, equity is not one person's job in the organization. If it's one person's job, unfortunately, that organization is not going to change, and it's not going to progress in terms of its mission to advance equity. Equity is everyone's job in the organization, and how you figure out how to make that charge the case is how then you can advance your mission. It's like how when you think about, again, actually, I love that Charles is bringing up things about lean methodology, since I'm a lean trained, quality improvement, physician. And so, one of the things that oftentimes comes up when you're thinking about lean and you're thinking about trying to improve the reliability of an organization is that quality is supposed to be baked into everyone's job, right? Everyone has the power to stop the line. That's what happens in a highly efficient, highly reliable production system. And I would argue that the same thing needs to happen for an organization to be truly equitable and to advance towards equity, in the sense that everyone in the organization should be empowered to stop the line. When you realize or you recognize that something is potentially contributing to inequities or something is contributing to existing disparities, everyone should have the power to stand up and say, hey, we need to rethink what we're doing as an organization, because we may be potentially inadvertently contributing to the problem that we're trying to solve. This was actually, there was a beautiful example of this, at our organization, where again, I'm the clinical lead for healthcare disparities, but there was one point where we were talking about our COVID vaccine rollout, and we were talking about what is the best way that we can ensure some type of equity. How can we prioritize our patients who are vulnerable? And I remember this beautiful email exchange that I was on, where, we were talking about our new doses, which were coming in. This was early on when we had so few doses to go around, right? And, new doses came in. Somebody immediately said, you know what, we should really be reserving this, for our patients who are most at risk, our socially vulnerable patients, right? We should be prioritizing. Someone else around 5 minutes later immediately emailed and said, that's a great idea. Why don't we actually reserve at least around, 20% of these doses and call our socially vulnerable patients first and reserve them a spot in line. This entire time, me, again, the individual who's supposed to be on this committee, supposed to be working in this organization towards equity, I didn't have to say anything, because we had already built the framework at that point. We had put in the groundwork to say, hey, equity is everyone's responsibility. Everyone is empowered to say something about it. It shouldn't just be the person in the room who's supposed to say something about it. Anyone can say something about it. So I found tremendous success in that regard. And the other thing that I would also talk about is really just foundational. We've heard so much great data tonight. One thing that I just want to emphasize and just take it back a little bit is that all that data is beautiful, and it's so useful in terms of thinking about solutions. But you also have to think about the foundational effect of just having that data in the first place. You need to think about putting in the types of frameworks so that you can collect that data. One of the issues that often confronts so many healthcare organizations is the fact that they don't have great data collection when it comes to these things like race, ethnicity, sexuality, and language. And because of that, if you don't actually have the data in the first place to know, what your patient population is, you're never going to know what the problem is before you can actually start addressing it. And so again, foundational goals are what I've found to be effective in this circumstance, making equity everybody's job. And again, getting the data first so you can define the problem and know what the problem is before you can start addressing it. So thanks, everyone.
Well, thank you so much to all of our speakers and panelists. I think you've left the audience very impressionable in terms of, all of your own perspectives, experiences that you brought to the table and share with participants. And really, it really speaks a lot to a lot of things that we do as part of the hackathon, right? Really focusing on, what the problem is and getting to the roots of what that problem is, as Dr. Gray mentioned, really find that passion, find that motivation, do the thing that makes you come alive to impact the issue that breaks your heart. The other, quote that came out tonight was, really thinking about designing for equity, right? Or for diversity. And I think, as part of this hackathon, highly challenge everyone to take that to heart and think about, making sure you have all of the stakeholders involved, not just, the clinician or the patient, but everyone that's involved as part of that problem, right? Because again, we have to make equity everyone's business. So thank you again to all the speakers. And with that, we'll transition very quickly to the rest of our evening. I know we're running quite a bit behind, so really appreciate everyone's patience. And I think I kept looking at the participant count, and it actually has not moved at all since the beginning of the session. So everyone has been truly captivated by all of you. So again, thank you all for joining us this evening. So